Assalamu alaikum. Thank you, Dr. Aqil, for the nice introduction. I would like to thank all of you for being here today. So I'm going to talk about the Early Arthritis Clinic, your window of opportunity. So we know that we're tending to diagnose patients earlier. So we believe that in the past, people tend to focus on well-established disease when it's too late to interfere and alter the path of the disease itself. So now we're tending to diagnose them as early as possible. So in a way, we can alter the path of the disease. So our learning outcomes are going to be the challenges of early disease, an approach to early arthritis, prediction of outcome of undifferentiated and early RA, and the rationale for early management. As all of you know, the RA is a common inflammatory arthritis. Sorry, but it's different than here. So as all of you know, RA is a common inflammatory arthritis. Untreated RA results in joint destruction, functional impairment, increased mortality, which we want to prevent it. The outcome of the disease, however, has improved considerably in recent years with the early diagnosis and the availability of different treatment. So in practice, patients with inflammatory arthritis should be seen as and recognized early and treated at the earliest opportunity. Clinician must differentiate between the early features of RA from other kind of arthritis which can remit spontaneously and from diseases that may present with polyarthritis. So again, the goal of treatment is early suppression of inflammation, establishing remission as early as possible in order to prevent joint destruction, disability, and mortality. So when we're talking about early, how early is early? So the concept of window of opportunity suggests that there is a limited period early in the course of the disease when the disease process can be altered or may be reversed with a complete return to normality. The start treatment with DMARD during that period may have a much greater effect in halting the disease progression and make a real difference in the outcome of the patient than treatment at later stage. So when we're talking about the early RA period, it's divided in two periods, which is very early RA, when the duration is less than 3 months, and the late early RA, which is when it's between 3 and 12 months. There are multiple studies which support that idea. There's done a non-blinded study of a single dose of corticosteroid in 63 patients with mild early inflammatory arthritis of median duration of 20 weeks, found that the strongest predictor of disease remission at 6 months while the symptoms duration of less than 12 weeks. Clinical and radiographic outcomes were significantly better in 20 patients with RA who started DMARD within 3 months of when the disease started. In this study, there's a significant difference in the DAS28 as well, which is a measure we use to assess the disease activity, in favor of the very early treatment group, which was evident already after 3 months of DMARD therapy. And also remission was achieved in 50% of the patients who started the treatment earlier. The importance of early treatment has also demonstrated in the randomized controlled trial of 417 patients with early RA treated with methotrexate plus minus etanercept, which is anti-TNF. Patients with symptoms duration of less than 4 months achieved significantly better disease control within a 40% increased rate of remission. They have lower disease activity scores and more likely did not have radiographic progression. So what are the challenges of early disease? The first few weeks or months of symptoms represent an important therapeutic window, as I said, in patients with very early synovitis who will develop RA. However, treating patients within this phase presents several challenges, which are predicting which patient with early synovitis will develop RA and thus require treatment, and determining how such patients should be treated. As there is no single diagnostic test or a combination of clinical features, laboratory test is used to make that diagnosis of RA at that early period. 1987 ACR classification criteria previously used to define RA. As I said, all our classification criteria was designed to diagnose patients with well-established disease. So the focus or the aim at that time, not to diagnose patients with very early disease. That's applied to different diagnoses in rheumatology, not only RA. Then a 1987 ACR criteria, when applied in early RA, have sensitivity ranging from 40 to 90%. So you're missing a lot of patients with early RA. So the poor performance of a 1987 criteria are concerned with a shift in focus in RA from established to early disease. Growing evidence that time to treat is a key driver of the outcome. So that make the ACR and EULAR publish their 2010 classification criteria to have more patients with early disease to be diagnosed as having RA. So it's a scoring system classification criteria where the patient scores 6 and above, so they're more likely to have RA. As a rheumatologist see patients earlier in the course of the disease, it's also become clear that proportion of patients who present with inflammatory arthritis may have what we call undifferentiated arthritis. So what's the outcome of these patients? That varies, and the diagnosis may change in the first year of follow-up. So we know that 30% of them will remit. That sometimes makes us think twice before starting these patients on DMARD, and 30% will develop RA, and up to 20% remain undifferentiated. So differentiating patients with self-limiting disease from all those at risk of developing persistent inflammatory and erosive arthritis, this differentiation allows to start appropriate treatment for patients whose arthritis disease will progress, avoidance of unnecessary treatment for those patients who the disease will resolve by itself. So what's the approach to early arthritis? The following steps have been suggested as an approach to the evaluation and treatment of patients with early arthritis. So you should recognize the presence of inflammatory arthritis at the beginning. So some patients will come with joint pain, but they don't have synovitis, they don't have arthritis, they will have arthralgia. Exclude patients other than RA or undifferentiated that present as an early inflammatory arthritis. Estimate the risk of developing persistent or erosive irreversible arthritis, and that depends on the patient characteristic. Using a combination of clinical feature, laboratory tests, and imaging techniques. Issue treatment and monitor disease activity, escalating treatment as required in order to achieve a favorable outcome. So the clinical evaluation remains the cornerstones for evaluating early arthritis. So we have to determine whether arthritis is present or not at the beginning, then differentiate between inflammatory or non-inflammatory disease, and determine the etiology of arthropathy. Remember, a lot of diseases can present with polyarthritis. Articular symptoms may be the presenting manifestation of many infectious, inflammatory, or malignant conditions. The clinical feature may also provide clue to identify those at risk of developing persistent erosive disease. So a thorough history should be documented, detailing the distribution of the symptomatic joint, duration of the symptoms, early morning stiffness, response to non-steroid anti-inflammatory drugs, and prodromal illness and associated symptoms. Family history is important, personal past medical history, including smoking history. A comprehensive examination of all systems should be performed to reach a diagnosis. Laboratory investigation and imaging are also a measure for the diagnosis and prognosis of patients with early arthritis. It's important to be aware of their limitation when interpreting the result, and imaging techniques are potentially helpful in this setting. So when the patient presents early and you can see signs of erosive arthritis in X-ray, so that's not a good sign. So that will tell you this patient may or most likely have an established disease. Prediction of outcome of undifferentiated and early RA, so assessment of disease persistence and assessment of disease severity. So that will help you to make the decision when and what to start at that time. So when we talk about assessment of disease persistence, so candidate predictor of disease persistence early arthritis, female gender, duration of the symptoms, higher tender and swollen joint count, hand involvement, cigarette smoking, positive serology, and as I said, erosion on X-ray. What about the assessment of disease severity? Many of the factors predict disease severity. Joint damage and functional disability are the two most common outcome measure of the disease severity. The most reliable prognostic factor of radiographic joint damage are a high acute phase reactant and the presence of a titer of rheumatoid factor and ACPA, and of course the early erosions. And also these are factors for the assessment of disease severity, again, female gender, raised acute phase reactant, positive serology, and erosive disease. So what's the rationale for early management? Remission implies a state without damaging and disabling. Spontaneous remission without treatment is rare in RA. So as I showed you earlier, it's around 30%. In most untreated patients, the disease persists and results in joint damage, functional decline, and premature mortality. Several studies have reported that DMARD-free sustained remission can be achieved up to 15% of the early RA. The joint damage and loss of function RA occur early in the disease process. So radiographic outcome studies have shown that 70% of patients with recent onset RA develop bone erosion within the first 3 years of the diagnosis. Within 3 months of the disease onset, 25% of patients have erosion evident on X-ray. More sensitive imaging techniques are MRI and MSK ultrasound, which are more sensitive than X-ray in detecting erosion. The MSK ultrasound detects at least 1.4-fold more patients with erosive than X-ray examination, and the prevalence of bone erosion detected in MSK ultrasound is reported as many as 60% of patients with early RA. So even if their X-ray are normal, there is no erosion, that's not very reassuring. Several studies have shown that delay in treatment is associated with poorer outcome. A meta-analysis of 12 studies in patients with RA and symptoms duration of around 2 years, an average 9 months delay with starting DMARD significantly increased subsequent radiographic progression. Again, there is a meta-analysis of 18 cohort studies and randomized controlled trial has confirmed that prolonged symptoms duration associated with radiographic progression and lower chance of DMARD-free sustained remission. The referral of the person with suspected inflammatory arthritis should be early. And however, the assessment of by rheumatologists is delayed about 18 weeks in patients having RA or SPA. And only 31% of RA patients are assessed within their first 12 weeks of symptoms onset. So please refer patients once you suspect they have inflammatory arthritis as soon as possible. Thank you.